Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner. To Melanoma Matters, I'm James Larkin.
Hi, I'm Sapna Patel.
Okay, Sapna, icebreaker warm-up question. This one's not scripted either, I'm afraid. Guilty pleasures, in as much as you feel prepared to say something. So, it could be TV, music, food,
Okay. If Law and Order SVU is on, that's a guilty pleasure. And I could, by the way, on Saturdays, I think it's on TV Marathon, so it's usually on in my house. French fries. I sort of consider myself a French fry aficionado. So I can tell if it's frozen, if it's fresh cut, if it's a double fry situation or a single fry. So I have a real
Whoa. Well, that's it. That's serious expertise.
Yeah. And then I feel like Paul Nathan's going to really endlessly tease me on this, but so he thinks I'm a big kind of American eating cheeseburgers, sneaking away at conferences to go find a cheeseburger. I'm probably that American who's sneaking away to go eat a doner kebab because I really like a good doner. In fact, in Munich, I shouldn't say this, but I skipped the speaker dinner and I door dashed in just doner and fries. And I did one actual, but because I'm really uncertain about pita and I don't really, the quality of it's usually not that good. I usually just like it as the salad and the lamb mixture or the beef mixture or whatever, and the veggies and the sauce and and then I put French fries on.
That's a proper guilty pleasure, isn't it? So was there ever a period in the US where French fries were called freedom fries or not? Or is that just what we read about in the press at the time?
Sure. Freedom fries. Yeah. There was a fun.
So when did they change back to French fries? Do you know?
So that was obviously, was that 9/11 when we changed it from French fries to freedom fries? Yeah. I don't remember, but I can tell you around 2011 or 12, there was a cool US program that came out called Scandal, starring Kerry Washington. And it was basically crisis management in DC. So she's a crisis manager based on a true story of this crisis manager, that worked in the Bush administration. And that show is so charming because every time they talk about going to get food or whatever, they talk about Gettysburger. So not Gettysburg, but Gettysburger. And they'll talk about things like union rings instead of onion rings. And I think they call them freedom fries there. They'll talk, they have some cute names for their burgers. And I definitely caught my attention when watching that series, how cute their fast food stuff.
Yeah, that reminds me that so one of our research nurses, she's Glaswegian, she's moved back to Glasgow now. And there's some sort of, I think it's kind of fast food type of joint in Glasgow called Lebowski's. And I didn't know this basically. And so she sent me a picture, and then all the food on the menu and all the drinks are basically straight out of the Big Lebowski.
Love that.
And all, there's pictures of yeah, exactly. And of course, there's 5 different types of White Russians or something like that. So that's quite a good link, isn't it? So Ipilimumab in uveal melanoma, which is what we're meant to be talking about.
Yeah, we don't have a lot of treatments to talk about in uveal melanoma. So we've done a podcast now on Tebi. This is our de facto standard of care for HLA A0201 positive patients. Great data in the frontline setting. Does it work in second line? I guess we don't know as much, but great data for frontline. But the obvious question that people would be thinking is, what about checkpoint inhibitor and what about combination? Because that's really what we should be using. Opdualag aside, first of all, 0 published data. Jose Letsky ran a phase 2 trial of Opdualag, Nivo, Rela for uveal melanoma. Let's wait and see if we see a publication on that. What we have had publications on is Nivo Ipi. So there were 2 studies sponsored by BMS on this, one in Spain, so throughout the country of Spain, multiple centers, and one unfortunately, single center study in the US. This had to do with budgetary reasons of, what the sponsor was willing to give us. These were actually both investigator initiated, I should say, with BMS funding. But so that really means that the sponsor is the main institution and not the pharma company. So these, the two studies were published as sister publications. So we were running the study at MD Anderson at the time. Joseph Piolats was running it in Barcelona and across Spain. And we were keeping up with each other. We knew when our results were, when we were finishing accrual. And so we were staying in touch. And then we communicated when we were writing the papers, and we said, should we try to just submit this together and see if they'll publish it back to back in the same journal? So we were so grateful when JCO accepted these. Maybe I'll ask you, is that something that you've coordinated? Have you ever done a sister publication like that for any of your big or small studies?
Once or twice, but not more than that.
Yeah.
I think in the world of science, obviously, as opposed to, let's say, clinical trials, this is obviously quite common. So I've been involved with, a few of those kinds of things. If it works, it's very nice, obviously.
Yeah. Some of the first neoadjuvant stuff was like nice companion work in Nature Medicine. But anyway, it was nice. And it's interesting because you realize you didn't collect the same data fields necessarily. And so it's, it makes it difficult to directly compare these. But let's start with the Spanish study. So the Spanish study was a proper frontline study, metastatic uveal melanoma patients receiving Nivo Ipi at that standard dose that we're aware of. And they ended up enrolling 52 patients in their intention to treat. And, a very nice study in the frontline setting. Not much to say about demographics. There is. Well, I shouldn't shortchange it like that. Because it's frontline, 64% were M1A, which is this less than or equal to 3 centimeters. A third, 31%, were 3 to 8 centimeters M1B, and a very small number were the large 8 centimeters untreated frontline. Interestingly, they had a couple of patients with brain metastasis, which we find to be exceedingly rare in uveal melanoma, but they did have a couple, so that makes it 4% of their study.
And did they genotype the patients as well? That's always going to be my first question, especially with brain mets and uveal melanoma. They did, right? Okay.
Did they genotype specifically those 2 brain mets? Well, so what I can tell you, because I know somebody who reviewed this, and I won't disclose, although I think you can find this stuff online. So he asked this site, you need to put your genotyping in the demographics table. Thank God we were not asked that, because at the time that this study was being run, my study started in 2011-ish, 11, 12-ish. We weren't routinely testing for these on these patients, and we didn't have a panel that had GNAQ and GNA11 on it. So thank goodness the reviewer didn't ask us, because we would have been, unknown or not typed in the majority, which doesn't look nice on a demographics table. So Joseph actually, as I recall, had to go back and pause, the response to get some of this genotyping performed. And it is, 72% GNAQ wild type, so 28% GNAQ mutation, 56% GNA11 mutation. Let me just pause to say there used to be this feeling that GNAQ, GNA11 were maybe 50-50 in primary tumors, and maybe GNA11 was more common in metastasis. Let's not hang our hat on that. Not every GNA11 patient metastasizes, and not every GNAQ patient is spared from metastasis. Very short answer. SF3B1 was mutated in 12. So GNAQ, GNA11 are homologous and essentially mutually exclusive, but SF3B1 usually can occur concomitant with one of those or with a wild type. And it just imparts probably a delayed phenotype for metastasis. So not metastasizing in 1 to 3 or even 5 years, but post 5 years. And then they did 3P and 8Q chromosomal alteration, but that's as expected. 3/4 of them have a 3P deletion and 8Q amplification, and those are probably overlapping populations. And they will overlap with the BAP1 mutation loss patient population had they sequenced that, but that's an expensive gene to sequence. It's not hotspot. LDH. So they looked at LDH normal versus less than 2.5 times upper limit or greater than 2.5 times upper limit. So that's kind of an interesting way of looking at it. So normal LDH was 52%, less than 2.5 times upper limit of normal. So normal-ish gets you another 17.3% on top of just plain normal. And then more than 2.5 times upper limit. This is a metastatic uveal involving the liver most of the time, but majority small volume, only 13%. So that's with a grain of salt, but think about it when you're treating these patients. That's really the bottom line. Let me now tell you about the US study that we did just for demographics comparison. Also Nivo Ipi, also non-randomized phase 2. But ours was any line. So you could have been treated at any line. Turns out the majority of these patients were treatment naive, but it bears importance to say that, it could have been previously treated. This study only enrolled 35 patients as compared to the 52 in Spain. We did sequence our patients, but I don't see that we did put it in a demographics table. So maybe good on us. Maybe we did do it and I just was misunderstanding. So we have the inverse breakdown. Ours is majority GNAQ positive. So 46% of our population was GNAQ mutation positive, with 14% GNA11 positive. And it was the inverse in Joseph's study that it was majority GNA11 positive. We were wild type in 3, but it's important to note a third of our patients were not tested. So, we were in an era where this was not routinely tested. It didn't impact your treatment choice. We were 80% liver involvement, whether that was liver alone or liver plus something else. And then a slightly different breakdown than Joseph's in terms of M1A, B, and C, just a higher proportion of M1B patients. So 50% M1A, 40% M1B, and then 11% M1C. And then we had 57% of our patients who had no prior lines of therapy. And that means systemic or, liver directed or surgery, anything like that. Let me just stop there. So in both of these studies, the main thing, the primary objective, let me make sure I get this right, was okay, I'm looking at Joseph's here.
We're going to pause the split anyway, aren't we? So.
Yeah. Primary endpoint 12-month OS. Okay, for him. For us, it was... I thought it was objective response rate for us, but I want to be sure.
I thought it was as well.
Yeah. Okay. So the primary endpoint in the two studies was different. In the Spanish study, it was 12-month overall survival, as defined from first dose death from any cause or, at 12 months. And then in our study, in the US study, it was objective response rate. So confirmed or partial responses. We had a target of 20%, thinking that would be an interesting response rate. In the Spanish study, I think they used the PUMA analysis, which was a multi-center meta-analysis as sort of a comparator. That might have had a 1-year overall survival of about 27%. So they were approximating 50% might be an interesting 1-year OS to reach. That's how they got their sample size calculation. So the bottom line is the objective response rates were similar but different. In the GEM 1402 study, it was 11.5% objective response, again, a treatment naive population. And in the US study, it was 19% in the treatment naive population, 18% in that total population intention to treat. So, numerically different. But anyway, that nevertheless, it tells you this combination is probably additive, if not synergistic, compared to either checkpoint alone. And then just a point to say that, my feeling was, based on the bias that I have, that we ran this US study, if Ipi-Nivo had been used in the TEBI studies with this, objective response rate of 18% and a median OS that we found of 19 months, I'm not sure the Tebi OS of 21 months, 21.6 months would have been statistically significant. The propensity analysis was done using Joseph's data set of 52 patients that were true treatment naive. And of course, there, the objective response rate was lower, 11.5%, and the median OS was 12.7 months. So you can see there how, 21.6 months would probably be statistically superior to this Nivo Ipi. So, I have no, other than to recognize my own bias, I have no hesitation to use Tebi. Tebi should be and is our first line treatment and probably does outperform checkpoint inhibitor. But I think it opens us up to some really interesting sequencing questions. Could you prime somebody with Tebi, move them to checkpoint, or the inverse? Could you start priming their immune system with the checkpoint, keep those T cells activated in a state, and then start magnetizing them over to the tumor sites using a ImmTAC or bispecific as it were. So, that's really what I wanted to say about probably Ipi-Nivo. And adverse events, nothing to really say other than this is what we saw in the cutaneous population. There might be somebody's hesitation who says this is a liver metastasis population. So aren't you seeing far more liver side effects? I'm not going to say more, and I'm going to save that for maybe a future publication that we might have coming, where we looked at the rates between cutaneous and uveal. The fact of the matter is you monitor your liver enzymes. You watch it. And when it hits a certain threshold, you pause what you're doing. You hopefully can avoid steroids or do, as we've talked in the past, a soft touch. But a lot of times what you should do is pause and get a repeat in some short course and make sure the trend is not self-improving, because sometimes you don't have to do anything but just exhale. So that's really it. Efficacy of Ipi-Nivo and some brief mention of adverse events. Should we talk about?
Yeah, thank you. So that's very clear. The only other thing I was really going to ask is about, do we know anything about response characteristics, meaning duration of response? These are small numbers, obviously, or any suggestion at all or comment on the shape of the survival curves here in comparison, say, with Tebi. So I'm just thinking out loud. Let's say you do respond to Ipi-Nivo if you've got uveal melanoma. Might you thereby have a chance of really long-term survival, which, as far as we know so far, doesn't seem to be that common with Tebi? Or do we not really know the answer to that question?
I know it anecdotally. I know it from the good responders on our trial. And the shape of the curve looks like a Tebi shape too. You have a drop in your PFS pretty rapidly, but you have an OS that's more graduated. That's the short answer. The longer answer is the characteristics of, so we had a few complete responders, two that I can think of. You're not going to see it in the publication because they were still ongoing on treatment, but they have turned into complete responders. And one had 5 lemon-sized tumors in her liver. I'm pointing to my liver. I was like, is this the right side? Because the camera looks weird. That looks like I'm pointing to my spleen. This is my right side, so that's my liver. So she had 5 lemons in her tumor, lemon-sized tumors in her liver that really melted very, very rapidly. And then another who had bone and lung mets that cured, went away. Both of them are still alive, doing well. One of them ended up with the brain metastasis years later, zapped that with local therapy, has been stable. The other remains in cure. So, for what that's worth, the one with bone and lung had an SF3B1 mutation. So that's interesting. The other, we never got any tumor tissue to be able to sequence. So the very first biopsy, unfortunately, was lost, as is embarrassing and heartbreaking to say, but certainly happens. And then every time we tried to biopsy her, she agreed to a biopsy. Every time we asked, and we asked her for about 4 or 5 of these, we got pigmented macrophages back. We got highly necrotic specimen. We never got any viable tumor. So there was nothing to sequence. So we don't know her mutation status, but one can presume she also has an SF3B1. So just bear that in mind, because she had a very long interval, maybe 19 or 20 years from primary tumor to metastasis. So that usually goes along with an SF3B1, but no idea about GNAQ, GNA11. What else can I tell you? We haven't gone really high in this, but maybe Joseph and I don't know if we can even go back to this data set and look at it anymore, but is it the M1As that are having this long survival curve? He has a nice breakdown, but yeah, it's not by M status. So hard to say. He's color coded some of his by mutation status as well. You asked about shape of the survival curve. Oh, okay. So there's an interesting analysis in one of the supplemental TEBI papers that looks at the at the partial response patients. There are no CRs with with TEBI, sadly. But if you look, or with Pembro, if you look at the partial response patients and just those on both the investigator's choice arm, majority Pembro, or TEBI, those curves actually are very overlapping. So if you're a responder to whatever, Pembro or TEBI, so you seem to get benefit. Is it long-term? It's hard to know if it's long-term, but those curves basically hang together and flow together. So that's to say, and by the way, we see that partial response up front. You see it at that first scan. So if at 9 weeks, 12 weeks, you scan somebody on checkpoint or TEBI and it looks like they're doing well, hang on to that because that looks like what they're going to do well on. Can you cross onto the other treatment and do well on that? We don't know any of that. What's going to be far more common scenario is at your first scan, you either have stable disease or progression. And then the question is what to do. So with stable disease, we often want to continue a therapy until you're actually having true progression. Mainly that's due to a lack of better options. Hopefully that will change. And with progression of disease, treating past progression with checkpoint inhibitor, I don't know that we have a lot of really good data on that, but certainly with TEBI, we have it. So if you are progressing on TEBI, there is data for treatment beyond progression. And like we were trying to say, it's worth taking the time to graph the slope of that curve. So if you have a 30% increase from where they started pre-TEBI, 30% increase at that first scan or at the scan where you're calling it progression, and then the next scan is 25% increase, you're still having progression, but you might start to think you're flattening the velocity or the slope of that curve. On the other hand, if you have 30% at the first time you check and you have 30 or 40% at the second time, you're either increasing the slope or you're not really flattening it, in which case you are probably bound to switch therapy sooner rather than later. So usually if I have two consecutive progressions where the number is not decreasing, the slope of the progression curve is not decreasing, then I start to consider a change after that second consecutive one. That's it.
Okay. Yeah, I don't have any other questions. So maybe to summarize that, so Ipi-Nivo and Uveal Melanoma, clearly less efficacy than in cutaneous melanoma and probably mucosal melanoma for the record as well. But nevertheless, there is some efficacy there. And I guess for people who aren't suitable for treatment with tebentafusp, then this remains something that's important potentially in the clinic. And then maybe for the people who are suitable for tebentafusp, the sequencing thing sounds really quite interesting for the future. And maybe really if there's a way to define the people who are potentially getting benefit from the treatment with Ipi-Nivo, I guess beyond the people who have kind of got the best biology disease. That's quite a strong message that's coming out here as well in terms of when you treat the patients. So I can't think of anything else. So I guess unless you can, that's a wrap.
No, that's it. Thanks.
Thank you.
Hey, everybody. I wanted to do a quick fact check on the Nivolumab plus Ipilimumab in uveal melanoma studies. We talked about two main studies, so let me start with the citations. The first one is Joseph Pilatz et al. This is the GEM 1402 study, the Spanish study. Journal of Clinical Oncology. I should absolutely know the year here because we published a sister companion study, 2021. So Joseph Pilatz, Journal of Clinical Oncology, 2021. And then the MD Anderson single center, single arm phase 2 Nivo Ipi metastatic uveal melanoma, Meredith Pelster et al. It's the same publication. For some reason online it's saying partial access October 2020, but we know it actually went to print in that January 2021. So the two articles are published back to back in JCO with an accompanying editorial from our good friend Rich Carvajal, who is a leader in uveal melanoma and now happens to be the big man in charge at Northwell Cancer Institute. He's physician in chief and leader of the oncology, essentially oncology service line there. So he wrote a nice editorial to our two companion articles. Let me just take you through some nuts and bolts of the two articles. In the GEM 1402 study, 52 patients with a median follow-up of 13.4 months. The MD Anderson study had 35 patients, 33 were evaluable for efficacy, median follow-up 13 months. So very similar follow-up periods there. The objective response rate in the Spanish study was 11.5%, 19% in the MD Anderson study. Median progression-free survival 3 months in the Spanish study, 5.5 months in the US study. Median overall survival 12.7, GEM 1402 study, 19.1 months in the US study. Just some slightly different efficacy metrics, but that could all be done because it was single center at MD Anderson. So we took, we had just a little bit more curation, if you will, of these patients, a little bit more control, and maybe that explains it. The Spanish study was multi-institutional across Spain. Grade 3-4 treatment-related adverse events. It was 58% in GEM 1402 and 40% in the MD Anderson study. The most common adverse events, this was interesting for me to remind myself. In the Spanish study, the most common in descending order were skin toxicities, fatigue, both of those occurring in more than half of patients, and then liver enzymes in about a third of patients. In the US study, the MD Anderson study, it was completely different. So the number one treatment-related adverse event was diarrhea. Number 2 was liver enzyme elevation. Number 3, pruritus. Number 4, hypothyroidism. So Spanish, it was skin, fatigue, liver. The US, it was diarrhea, liver, pruritus. So it makes you wonder if we're asking the patients about adverse events differently to generate different responses, or if there really is a global difference in adverse events. I suspect it's all in how we're phrasing it. Maybe skin toxicity comes out as pruritus for us as opposed to an overt rash. But anyway, I find it interesting that our most common was diarrhea, and it was skin toxicity in the Spanish study. Diarrhea wasn't even in their top 3. So I think that's it for the fact check. So thanks, everybody.